throw 7. We have a prone technique, and we have a prone technique. On your stomach. Foot on the floor, right foot. So when do you use the mold? When necessary. Always start with your muscle energy. If you get the job done with muscle energy, the myofascial, so much the better. But when the joint feels stiff, and you want to put a little more local force in, then we can take, with a stable right side, we can take the hypothenar contact on the iliac crest, take the hip into extension and a little bit beyond. I'm going to add a little bit adduction. I'm going to take the left innominate, anterior or ventral, lateral and superior, iliac crest for the superior pole, PSIS for the inferior pole. So if I'm wanting to effect a change at the superior aspect of the SI, I bring him into hip extension, adduction, and here's my force right in through here. With this hand, ventral, lateral, and superior on the iliac crest. I want to come down to the lower pole, lift him up a little bit higher, and get on the PSIS, same ventral, lateral, and superior mold. Okay, so that's easy, that one. You have one position, 2 poles. No, ischial tube will rotate posteriorly. We want to rotate anterior now. I think we'll work against ourselves if I do that, because the hip is taking him anterior, and then that force is taking him the other way. Yeah, you want to be on the other side of the hip to rotate it anterior. If I'm on the inferior side of the hip, I'm going to posteriorly rotate. If I'm on the superior side, I'm going to anteriorly rotate. Alright, while we're here, the home exercise, the same exact position. Bend your knee a little bit for me. Good. And give me a push down into the table. Great. Contracts his iliopsoas on the affected side. That will give him that anterior rotary force. If we want to have him increase the force, just walk up a little bit. Bend your right knee. There you go, a little higher. Now push down. Good. And that's taking him more and more into hip extension, more and more into anterior iliac rotation. Good. Thank you. Again, we have to think about ways to prevent the recurrence. So with the posterior innominate, we're going to think about the baby on the hip. Unilateral leg standing, just favoring the one side. We're going to think about hamstring tightness. We've got to stretch the hamstring. If we have a chronic anterior iliac rotation, we've got to think about stretching out all the influences on the ventral side. TFL muscles, tensor, rectus, iliopsoas. Definitely, if you just balance muscles, you're going to probably correct a lot of these things. Just like in the article I gave you, they just worked on the hip flexors and they derotated an anterior innominate. You've got lots of tools, you try different things, but as a general rule, start with the soft tissues before you work on the joint. Because once you over-mobilize a joint and you make it hypermobile, you're stuck with it. You don't want to create hypermobility. You'd rather treat hypomobility any day. Much easier. Once it becomes unstable, it's much more difficult. Then you have to stabilize it. If you're going to make mistakes in the beginning, make your mistakes on the soft tissues. They're more forgiving. They'll be sore for a couple days. You overmobilize the joint, you make them sore for a week or 2. All right, let's try that.